The iScoop makes intubation and the spontaneous breathing practical, turning a complex, rarely used technique into routine care. This safest way to secure the airway is now poised to become the new standard for all patients. Alfred Kirstein showed 130 years ago that direct laryngoscopy requires straightening the airway with pressure and force. All modern video laryngoscopes are descendants of that first blade-based design and follow the same principle. The iScoop is the sole exception. That blade-based legacy still dictates practice today. Securing the airway while the patient continues to breathe spontaneously is extremely rare, only 0.2% of cases. Existing methods are too invasive or too complex, too labor-intensive and insufficiently standardized. Guidelines point the other way. They favor intubation with preserved spontaneous breathing, yet adoption remains minimal. Even when a difficult airway is anticipated, it is used in only 2.7% of cases. Consequences? With an anticipated difficult airway, serious complications occur about 45-fold more often than with a normal airway. Overall, the rate of serious complications is roughly 0.028%. With about 10 million general anesthesia cases per year in Germany, that implies roughly 2,800 serious complications. In the ICU, serious adverse events affect nearly every second patient. And how many times more frequent is that compared with the overall elective general anesthesia population? A 1,600-fold increase in serious adverse effects. This is not marginal, it exposes a systemic weakness in the current standard. We need methods that increase safety before complications occur. That requires a fundamentally new approach, safer, simpler, and as minimally invasive as possible. By rethinking this sequence, separating airway management from general anesthesia and returning it to protected patients who keep breathing on their own, we gain 7 advantages. No neuromuscular blockers, a much lower anesthetic load and better hemodynamic control, preserved spontaneous ventilation with reduced hypoxia risk, less invasive vision-guided intubation with few injuries, personalized titrated dosing, real-time CO2 confirmation of tube position, and reduced aspiration risk as protective reflexes are largely maintained. The upper airway is not a straight tunnel. Under analgosedation with spontaneous breathing, we must follow the airway's natural curved course in a tight mobile space, often laden with secretions. The task is not merely to see the glottis, but to guide the tube in a controlled, straightforward manner through two 90-degree bends. This is where everyday clinical practicability is decided. The status quo fails for mechanical reasons. Even in experienced hands, the glottis is only partially visible because the epiglottis cannot be lifted sufficiently and obscures the view. To obtain the clear view needed to judge whether the glottis is open or closed, the epiglottis has to be uploaded, and progress comes in tiny steps. Blade-based laryngoscopes require straightening an S-shaped airway to some extent to obtain glottis view. That demands force, soft tissue pressure, and stimulus. If we try to limit stimulus, we add complex maneuvers such as uploading the epiglottis with a blade. Nudge, withdraw, change the angle, repeat. 20 micro attempts later, almost 2 minutes pass before the tube is in place. Under analgosedation with spontaneous breathing, every extra maneuver can trigger reflexes and movement. The safety margin shrinks. As long as intubation is this complex, spontaneous breathing approaches remain limited in everyday practice. So the question is not whether teams can do better. They already perform at a high level. The question is when mechanics align with physiology, when seeing, guiding, and acting follow the natural curves of the upper airway instead of fighting them. The epiglottis again occludes the view, making vision-guided placement impossible. The tube advances blindly without visual guidance or confirmation of tracheal entry. And what cannot be seen cannot be controlled. Blind intubation is a failure mode, not a plan. It is an avoidable risk, unreliable by design and unsafe in practice. With the iScoop, mechanics change. Dual optics and the tube guiding bar are anatomically guided into a subepiglottic position, yielding a stable two-perspective close-up. The viewing axis and the working line meet at the laryngeal inlet. Easy, safe, and ready for routine use under spontaneous breathing. Patented and approved, in clinical use and continuously refined since regulatory approval in 2021. Similar to a laryngeal mask, the iScoop is inserted anatomy guided without a blade. A finely controllable epiglottis lifter gently opens the laryngeal inlet with minimal force and very low stimulus. Dual optics and a tube guiding bar are now directly in front of the laryngeal inlet, enabling stylet-free, vision-guided intubation. Seeing and acting on one line delivers control, safety, and everyday practicability. But what if gastric contents regurgitate during intubation? And how often does that occur? Under general anesthesia, protective reflexes like laryngeal closure and cuff are abolished, allowing gastric acid to reach the lungs and cause severe lung injury. In hospital, respiratory failure from aspiration of regurgitated gastric contents occurs in 1 in 500 patients after induction of general anesthesia, alarmingly frequent for a life-threatening complication as shown in a prospective Lancet study. That is in hospital. However, how often do patients aspirate in out-of-hospital emergencies where conditions are less controlled and cases are more severe? About 90 times the in-hospital rate. In helicopter emergency care, CMAC video recordings documented ongoing aspiration or visible aspirate at the glottis or upper trachea in nearly 1 in 5 patients. Therefore, airway safety requires 3 capabilities. First, protective reflexes, including laryngeal closure and cuffing, should remain as intact as possible. Second, intuitive airway decontamination that clears fluid early to maintain vision and reduce the risk of gastric aspiration. Third, safe, rapid, vision-guided intubation. The iScoop closes the safety gap by integrating airway control and airway decontamination in one device. With the iScoop, the optional dual suction system rests at the lowest point of the upper airway, directly in front of the esophageal inlet, where secretions, blood, and gastric contents first accumulate. The suction slide keeps the view clear. In addition, under analgosedation, protective reflexes are largely preserved, further reducing aspiration risk, a double gain in safety. This delivers practical protection where it matters most, emergencies and high-risk patients. No other system offers an equivalent solution. The iScoop moves airway management from reaction to prevention and makes safety the default by design. On the left, you see targeted topical tracheal anesthesia under direct vision, precise, rapid, reproducible. On the right, about 1 minute later, vision-guided tube placement, safe, straightforward, no extra maneuvers. This isn't just for difficult cases, it also works for elective patients with normal airways in everyday care, because it's simple, practical, and a better way for everyone. Every patient benefits. No neuromuscular blockade, much lower anesthetic doses with steady hemodynamics, faster recovery, and few adverse effects, including less sore throat, dysphagia, and vocal fold irritation. And that's exactly why the concept scales. Make it the default for uncomplicated cases and you build real routine. Routine on easy cases builds competence for the difficult ones, especially in the sickest patients in ICU and in emergencies. The iScoop moves a rare exception to standard practice. It makes intuitive, vision-guided intubation with preserved spontaneous breathing practical as routine care across anesthesia, intensive care, and emergency medicine. By making the safer way the standard, the iScoop turns risk into reliability and makes routine care safe by default.